Cardiovascular prevention usually prioritizes cholesterol, blood pressure, and smoking, but homocysteine is a distinct amino acid acting as a potent, independent risk factor for atherosclerosis. Elevated homocysteine acts like jagged particles that aggressively bombard the smooth vascular wall, causing the tissue to visibly inflame and microclots to begin forming. High levels of homocysteine drive endothelial dysfunction. This means it directly impairs the inner lining of the blood vessels and triggers prothrombotic changes, altering the blood's chemistry to make it more likely to clot. This biochemical process is separate from the damage caused by high blood pressure or lipid accumulation. A typical patient can maintain an ideal lipid profile and still experience vascular injury if their homocysteine remains elevated. Managing cholesterol while ignoring homocysteine allows a specific, verified pathway for plaque progression to continue unabated. There is a massive discrepancy between what genetic studies tell us about homocysteine and what our clinical trials have managed to prove. On the left, genetic studies of people with naturally low homocysteine show a clear reduction in heart disease risk. But on the right, major controlled trials like HOPE-2 and NORVIT show the opposite. Despite B vitamin interventions, they found no significant reduction in cardiovascular events. If the genetic data proves that low homocysteine is protective, why did the medical interventions fail to save the patients in these trials? The conflict between the genetic evidence and the trial data suggests that our current approach to treating this risk factor is incomplete. To understand the failure, we have to look at how the body clears homocysteine. Instead, it relies on two specific exit paths: re-methylation and transsulfuration. In the re-methylation path, the body converts homocysteine back into a safe amino acid called methionine. This conversion requires two specific cofactors, L-Methylfolate, or 5-MTHF, and Methylcobalamin, which is the active form of B12. These must be the bioactive forms for the cellular machinery to utilize them directly. Without these specific biochemical forms, the re-methylation pathway stalls, and homocysteine concentrations rise back to toxic levels. The second path, transsulfuration, converts homocysteine into cystathionine. This process is entirely dependent on pyridoxal 5-phosphate, or P5P, the active form of vitamin B6. Most standard supplements use synthetic folic acid and cyanocobalamin, but these often fail to clear the bottleneck. As the diagram shows, synthetic folic acid must be converted by the body, but it frequently hits an enzymatic roadblock. This roadblock is often the MTHFR genetic variant, which prevents the body from turning synthetic vitamins into the active cofactors it actually needs. MTHFR is the gene that provides instructions for making an enzyme involved in processing amino acids. Active forms like 5-MTHF and methyl B12 bypass these genetic defects entirely. They provide a predictable biochemical impact because they are already in the form the body requires. For much of the population, relying on standard synthetic B vitamins is an ineffective strategy for vascular protection. If we audit the data from the HOPE-2, VISP, and NORVIT trials with this in mind, the results become much clearer. The interventions in these trials were actually successful at changing blood chemistry. As these data cards show, they reliably lowered homocysteine by more than 20%. However, they were not successful at changing clinical outcomes. The rate of heart attacks did not drop. There was a slight benefit noted in stroke prevention, but for heart disease, the numbers didn't move. These trials demonstrate that lowering homocysteine levels does not instantly resolve existing structural vascular damage. This brings us to the duration of exposure hypothesis, which explains why the genetic data and the trial data look so different. In genetic studies, individuals have low homocysteine their entire lives. This 60-year timeline shows lifelong protection preventing plaque formation. In contrast, clinical trial patients have 50 years of high homocysteine and plaque buildup. A brief 5-year vitamin window lowers homocysteine, but structural damage remains. Lowering homocysteine prevents the endothelial injuries that lead to new plaque, but it is not a tool for scrubbing away advanced calcification. Homocysteine management is a long-term protective strategy, not a short-term intervention for advanced disease. To apply this, we have to move from theory to a precise clinical protocol. Implementation starts with baseline testing, plasma homocysteine, serum B12, folate, and standard lipid and blood pressure checks. If levels are high, the therapeutic range typically involves 400 to 800 micrograms of 5-MTHF, 500 to 5,000 micrograms of methylcobalamin, and 2 to 5 milligrams of P5P. It is necessary to retest after 8 to 12 weeks. This confirms the dosage is effective and identifies non-responders who may have underlying absorption issues. This converts a complex biochemical problem into a measurable, manageable prevention plan. Because the supplement market lacks strict FDA oversight, you cannot always trust the labels. To ensure you're getting the active forms, you should request a certificate of analysis from the manufacturer. This document, as shown here, verifies the actual potency of the ingredients and screens for heavy metal contaminants. You can also look for independent verification seals from organizations like USP or NSF. Remember, this regimen is a supplemental tool. It is intended to work alongside, not replace, proven therapies like statins or blood pressure control. Effective prevention requires a unified strategy, managing traditional risks while maintaining